want to do in this talk is to look at some concepts of pediatric and adolescent hip reconstruction, to really highlight some of the principles that we use for a variety of conditions. Some of those you may be well aware of, but just to remind ourselves of some of the issues we need to deal with, and also to think about the goals of what we're trying to do with joint-preserving surgery, which is what this is all about in this case. So this young lady came with DDH as a child. She had a failed conservative treatment for DDH. She had an open reduction of hip. This was followed by femoral derotation osteotomy, and unfortunately she ended up with avascular necrosis. And then she came as an early teenager with this hip and ended up with the joint replacement surgeons, who went on and did this joint replacement on her. And 3 years after that, she's now 18, going on 19, she came to my clinic, and I asked her, I said, "You've had a hip replacement, are you any better?" And she said, "I am no better than I was before." I said, "Well, that's kind of hard to believe when you had such a bad hip anyway. Surely you must be better." And she said, "No, I'm not any better in terms of what I'm trying to do. I still have hip pain, I've got back pain, my right hip hurts, and my right knee also still hurts." So what's the issue? So what you see here is, in fact, unfortunately, they've not quite fully corrected the abductor lever arm. They didn't get the trochanter far enough down. They also didn't increase the offset enough, so we've got abductor muscle insufficiency. Because it had been a long-standing problem with range of motion in the hip joint, she's ended up with a bit of iliopsoas contracture. She's got some adductor contracture. I can see from this X-ray that she has some internal rotation deformity of the femur, often after the previous derotation osteotomy she had as a child. Because of the adduction and contractures here, she has a relative leg length difference between the two sides, which means she's standing with a slightly bent knee, which gives the appearance of that position of being slightly varus. In fact, clinically, she's not varus, she's actually valgus on that particular side. And because of this conduction contraction, the position of the hip joint, she's got a slightly oblique pelvis, which means she's got a little bit of a curvature in the lower part of her back, and hence the back pain. So in terms of limb reconstruction, it's all very well giving her a hip replacement, chopping the joint out, but you need to look at the whole patient, the muscles, the soft tissue, rotational issues in the limb. This is what limb reconstruction is all about. How do you manage this hip over the lifetime of the patient? What are we seeking to achieve? And I think very often with these cases, at the moment, biomechanical reconstruction is what we're trying to achieve. We'd like to preserve the cartilage, as previously mentioned, and the condylabral function I've talked about, but often in preparation for joint replacement at some point in time. This lady came to my clinic, 65 years of age. She had never been seen for hip problems in the past. She had a normal life, she had worked, and she had a family. And for the first time, she came complaining of hip pain, and she had bilateral high congenital dislocations of the hips. So those hips had lasted her a lifetime. Can we, in our reconstructive work we do here, tell our patients in the clinic, yes, your hip will last you at least 60 years after our surgery, and at the moment we can't do that. So in early stages of pediatric conditions, we can perhaps preserve this hip joint. Like today's case you've just seen, to all intents and purposes, she'll end up with a normal joint, and that joint should last her lifetime. But if the children come in the sort of adolescent, young adult stage, where they may have had an injury, morphological changes, etc., our reconstructive techniques may be more either reconstruction, salvage, or going on to early hip replacement. So looking at hip ontogenesis, and this is the study of the morphology of hip from fetal to adult life, we can see that the pathomorphology is determined by three factors. Genetic factors, that's the quality of cartilage you inherit, abnormal load patterns, and also adverse growth events. If you get Perthes disease or streptopiphysis, you may have had a normal hip, obviously that's going to affect the life of that particular hip. And biomechanically, we've talked about this, the Bombelli sourcile, orientation of the cup over the head, but also we need to think about these lever arms, the load of the body versus the body lever arm against the abductor muscle power and the abductor muscle lever arm. And those are the biomechanical effects we try and think about to reduce the force going across the hip joint and more evenly distribute that force across the hip joint. So the three key areas we look at are the trying to improve our treatment outcomes and options we have. That's our goal. Ideally, we want to deal with the cartilage, and obviously the holy grail would be if we can prevent these conditions from occurring in the first place. So in terms of what the patient's situation is concerned, this is largely biomechanical. Can we improve their symptoms by what we do? Can we still maintain an impingement-free range of motion with good muscle power, which translates into an energy-efficient gait, with an acceptable work-life balance without compromising the subsequent hip replacement that they may well have. So how are we doing? And there's a number of studies, we can even go through them all, but a number of studies looking at the variety of reconstructive options we've been using in the intermediate and short term to see, are we indeed achieving those particular aims I've just mentioned? But all these outcome studies show a significant deterioration and these patients going on subsequently to hip replacement. So this was an interesting publication which looked at the natural history of structural hip abnormalities with the potential for hip-preserving surgery. And the conclusions were that, yes, structural deformity does result in osteoarthrosis, an increased risk of osteoarthrosis, but that not all patients with identifiable abnormal hip morphology went on to develop osteoarthritis. And often that's the cases where you may have good or bad genetics. So the question was, how far do we go in terms of prophylactically correcting these patients? And this case we've just done, the live case, is in question. That mild dysplasia, there was a question about that mild dysplasia. Do we correct it? Don't we correct it? Is that patient predicted to go on to osteoarthritis? Or if she has good genetics, will she never get osteoarthritis? And that's the difficulty we have. We can't really make those definitive decisions just yet. So if we are going to do hip replacement in these patients somewhere down the line, how are our joint replacements doing in young adult hips? So this is from our joint registry now. We have a very huge number of joints on that registry now, hundreds of thousands. In the under 55-year-old patients of all pathologies, we see that at 14 years at the moment, that those joint replacements under 55 are doing equivocally to those in the 60 to 70s, providing you use a hybrid technique of joint replacement, that's ceramic poly or ceramic bearings. They seem to be doing the best. So at least they are doing as well as the sort of middle age group osteoarthritic patients. So joint replacement is still a reasonable option in these patients. If we are going to reconstruct the hip, what do we need to think about? Well, the acetabular cover, which we've talked about, the head sphericity, which is congruency, cartilage quality, range of motion, the muscle power, and we can measure things like the neck shaft angle and the medial proximal femoral angle or lateral proximal femoral angle in terms of mechanical axis planning. We can measure these and see how abnormal they are. And that translates into greater trochanteric height or offset, in other words, abductor muscle power. Level of osteotomy is important because we need to also decide to we need to importantly correct the mechanical axis of the overall limb. And our outcomes will depend on our specific morphology, the patient's activities. And we know this from Sufi patients. Often with Sufi patients tend to reduce their activities or change their activities to adjust to their hip problem, and obviously genetics. So I'm going to use a couple of pathologies that you see here to illustrate the different points of hip reconstruction. Developmental dysplasia, you know, presents in about 4 ways. You can give it very early on, untreated, from age of birth up to about 4 or 5 years of age. Dislocated hips, and we'll treat them as you saw today. So, or they can have a previous history where they had the condition and they've been treated, but are left with residual dysplasia and or problems. Or they've had no history or treatment, and incidentally you find dysplasia at a young adult. They come to a clinic for a reason, some hip pain, vague hip pain. The X-ray shows dysplasia. What do you do about these patients? Or they do have hip pain and dysplasia with or without prior treatment. And obviously from early age you can have these kind of treatments, and we know that the osteotomies available to us are things like Pemberton osteotomies or Salter osteotomies or Daiger osteotomies, and they either are reorientation osteotomies or they are reshaping osteotomies. The triple osteotomies originally described by Tonus, modified by Hungerford. The modification was either go above the lesser spine to release the sacrospinous ligament or not. And the importance of that sacrospinous ligament is that ligament provides a tether to the correction of the acetabulum. If that is still attached, then that will dictate just how you can manipulate and maneuver that acetabular fragment, and sometimes you'll get retroversion if you don't release it. The O'Hara interlocking osteotomy is one where you actually design these cuts at a specific angle depending on the angle of correction that you want from your preoperative planning. Or you can use the Bernese type triple osteotomy. This is a reorientation osteotomy to which you can add a reshaping component to it. So you do a osteotomy like you would for a triple like you saw today with this particular angled cut like you saw in the case we've just done. But that leaves you a nice bone block here, so you can go into this bone block, and if you have a source seal that is not quite the right shape you want, there's some incongruency, you can add a Pemberton type effect to it and therefore do a reshaping to your reorientation osteotomy. And then you have the periosteal osteotomy that you've just seen. So the remaining questions that we said beforehand is what we do with these asymptomatic patients, these borderline cases. Do we operate them? Do often operation? And at the moment, I don't think we have the literature or the outcomes to really decide which of these patients would benefit from our intervention. So are we actually making a difference? Well, this top paper here looked at, can we modify the cartilage or improve the cartilage by reorientation? And yes, we can. And we're also going to use these scans to correct the situation. We talked about the optimum case in terms of PAO. So let's look at proximal femoral deformities. And this is really a situation where, if you remember the growth plate that was described by Siffert in 1985, this is a continuous growth plate here. And you can see this in this particular image here. And consequently, depends on where in the growth plate the injury occurred will determine the type of morphology that you see in the proximal femur. So in coxa vara, it's likely to be, because it's in the head here, it's likely to be congenital, developmental. If you do your deformity planning here, your chora, or the apex of your deformity, is in the middle of the femoral head. Therefore, your plane of interest, that is the bisector line, that's the line along which you would like to do your osteotomy, the line on which you would like to correct it, goes through the center of the femoral head. In coxa valga, it's often neuromuscular, so the morphology or the development of that morphology is slightly different, and you find that your plane of interest, your bisector line, goes through, again, it still goes through the growth plate, but here at the lesser trochanter. So let's look at the implications of that. So if you're going to do a valgus osteotomy for a varus deformity, as you see here, you are going to require to translate this bone. The reason for translation is that the osteotomy you're going to do is at a different level to your bisector line. As soon as you go away from your bisector line, from that plane of interest which goes through your apex of your deformity, the further away you go, the more translation you're going to get. And therefore, the further down here you get, the more translation. In order to maintain correct mechanical axis of the limb, you need some translation. The same, and this is also going to affect, the level of osteotomy affects also the muscles around the hip joint. So if I do an osteotomy and I do it below the lesser trochanter, I'm going to detension my iliopsoas muscle and ligament. If I do the osteotomy above the lesser trochanter, I'm going to tension the iliopsoas ligament. And then your patient, for example, a cerebral palsy patient who may well have tight iliopsoas or contractures of iliopsoas, they may well be relevant as to the level of osteotomy due. Equally, if you move and do a varus osteotomy, as you saw in the case that was just presented now that we can operate later on today, that trochanter is going to move, and it goes up, which means I'm decreasing the lever arm of the abductor muscle, that abductor muscle force. So I'm affecting lever arm, which means in some situations you may get a bit of a Trendelenburg, some weak abductors. And therefore, you may want to think about, well, I need to do something about the trochanter, not only a varus osteotomy, but a trochanteric transfer, for example. Equally, with a valgus osteotomy, with a varus osteotomy for valgus deformity, this is where we want to do the osteotomy, up here. You still will require a little bit of translation, not as much translation, because you can see my osteotomy can be fairly close to my plane of interest, to the bisector line. So therefore, the amount of translation I get, which I know will be just this much here, at this level. If it was down here, it would be this much translation. So the further away you go, the more the translation. It's only going to be a little bit of translation in order to maintain a norm or to normalize the mechanical axis of the lower limb. Equally, the level of osteotomy will be affected, or the iliopsoas muscle will be affected by the level of osteotomy, and I'll show you a case where that is relevant. But also, not only does it that, but it affects leg lengths. So if you do a varus valgus osteotomy, the center of the femoral head will go up or down. So you get a leg length change, and you can plan that out preoperatively, and obviously warn the patients about the fact they may well get a leg length change with a varus osteotomy, and you may need to do something about that with the opposite limb or just a shoe raise. But equally, also, the position of the center of the femoral head, which is the starting point of your proximal femoral mechanical axis in deformity planning, will change. And so this is what we call a reverse planning technique you need to use, like you do for a lengthening nail in the distal femur. This was published by Baumgarten, that you need to do your planning from the center of the femoral head where it will be after your osteotomy, not where your starting point is, because it may be different from that. And therefore, your planning may be different to that. We'll just skip through this for the moment. Sorry. So let's look at some different changes in terms of the abnormalities of the proximal femur. we're looking at neck shaft angles. So the medial neck shaft angle is this angle here. Tip of trochanter, center femoral head, axis line of the shaft, medial proximal femoral angle. The axis line of the neck and the shaft, the medial neck shaft angle, this angle down here. And this is the lateral, this is mechanical axis planning, this is anatomical axis planning. And we have three scenarios. We can see that we can have a change in the medial proximal femoral angle and the neck shaft angle, and the magnitude of that deformity is the same, so say 20 degrees. Both are the same. Both are equally abnormal. Or we can have an abnormal medial proximal femoral angle, but the neck shaft angle is normal. Or we can have both angles being abnormal, but they are differently abnormal. So one may be 30 degrees, and one may be 50 degrees. So how do we deal with those? So if we look here where we have a abnormal lateral proximal femoral angle, but we have a normal medial shaft angle, the problem here is the greater trochanter. If we do a greater trochanteric lateralization or distalization, we will normalize the lateral proximal femoral angle, but the neck shaft angle remains unchanged. This often occurs in trochanteric overgrowth, or for example like Perthes disease, where in fact you may also want to be correcting the shape of the femoral head, and therefore doing an offset procedure. So Perthes disease classically is a condition that gives us a lot of options in terms of reconstruction. It has a lot of abnormalities. You have often acetabular dysplasia, you've seen earlier on, with or without incongruence. You have a cam deformity, a large head, coxa magna. You have a short neck, coxa brevia, high-riding trochanter, a short neck lever arm. Also, you have multiple points of impingement. So this is a 3D motion analysis looking at the case, and you can see that in all these different positions, different parts of that proximal femoral abnormality will cause impingement. So we're starting to understand extra-articular causes of impingement, sometimes posteriorly, sometimes a lesser trochanter, sometimes a greater trochanter. So these are all sources of pain outside the hip joint they need to be aware of. So what's the Wagner osteotomy? The Wagner osteotomy is an osteotomy where we're doing a valgus osteotomy for a varus problem. The neck shaft angle here changes. This hasn't changed yet. And you notice also that the femoral head, as you do the varus osteotomy, its orientation relative to the acetabulum will change. And if you still have an abnormal medial proximal femoral angle, you may want to also transfer the trochanter. So it's a varus osteotomy, neck length, angle changes, and you may have to transfer the trochanter. But the orientation of the head to the acetabulum changes. As opposed to the Morsha osteotomy, and you'll hear about this a bit later on, the orientation between the head and the acetabulum does not change. It's a neck lengthening operation, and you also transfer the trochanter. But the neck shaft angle here is determined by the angle that you cut that particular part of the bone. And this will go into more detail later on. You can also add head reduction osteotomies if you have asphericity of the femoral head, beyond which you can't do just a head-neck osteoplasty. Then you may want to change the shape of the femoral head. And there's this complicated operation that was originally described by Professor Reinhold Ganz, and I know Dror Paley has published on this as well. It's quite a complex procedure, and the problem with this is the difficulty in exactly matching the sphericity of your head to the acetabulum. What you often end up with is still a degree of incongruency, which you know very well this hip will not last a long time, but can give short-term results. What about subcapofemoral epiphysis? Well, this is a condition that has a number of options in terms of treatment. And if we look at this paper down here, that the patient-generated outcomes in terms of the symptoms of the patient are not particularly good, even for those pinned in situ in fairly mild cases. So let's look at the osteotomy logic and the deformity. This is the normal situation. This is subepiphysis. You can see here that the neck shaft angle has not changed. There's no change between the neck and the shaft, or the trochanter and the shaft. This is on the lateral view. Again, the anterior neck shaft angle does not change, but that's where the slip occurs. So if we look at that deformity, you can see that in this plane, superior-inferior, we have an angulation, 10 degrees, but we also have a translation. You can see where the apex is. In this situation here on the lateral, we have posterior, that's anterior, you have a posterior angulation, and we can map that out on this vector diagram. And what you can see is, on that vector diagram, that you have an oblique plane angulation. This is an oblique plane deformity. So you have angulation in one plane, angulation in another plane. It's not two angulations, one angulation. So you can see with the effect of this tie is that if I angulate around this one axis of my tie, I get pure angulation. As soon as I make that axis oblique, I get angulation and rotation. So when you see your slip epiphysis patient, his legs like that, it's rotated. It's not really rotated. It's because it's an oblique plane deformity, that's where you get the rotation. Is rotation important? And this has been mentioned before. So yes, if you rotate the trochanter and the trochanter goes backwards, can you see how this abductor lever arm is going to change? The extensor lever arm changes as well. So rotation the proximal femur is fine, but it does alter where your trochanter is. You need to bear that in mind. So this is a case where this child had, and it was mentioned before about knee pain and malignant malorientation syndrome. This patient came with bilateral knee pain to a colleague of mine. He chose to do proximal femoral derotation osteotomies. You see on both sides, all nicely healed up, all fine. She was asymptomatic on the left side. Her knee pain disappeared. On the right side, her knee pain disappeared, but she had persisting hip pain. 2 years of persisting hip pain until I saw her. And what you see here is that the level of osteotomy on the two sides was done at a different level. On the left-hand side, it was done just above the lesser trochanter. On the right-hand side, just below the lesser trochanter. If you look at the CT image here, you can see the angulation of the lesser trochanter on two sides is different. So she had her iliopsoas tendon was changed and it was impinging, causing hip pain. So we revised the osteotomy on that side to above the lesser trochanter, resolved the hip pain, and she now has knee pain again. So she's got a distal femoral derotation osteotomy this time. So level of osteotomy and rotational osteotomies are important. Think about what you're doing with them, why you're doing them, and where you're doing them. So in terms of the slipped epiphysis, back to that again, it's a variety of deformity. This deformity is mild. You want to pin that in situ, but in fact this is probably a bad one because that actually fits inside the hip joint. So that bump will be rotating inside the hip joint at the condylabral junction area. Just the area we've talked about and said it's very important in maintaining the integrity of that condylabral junction. This patient, his cartilage will last a long time because you can't get the hip joint into the hip joint. It doesn't move. That bump hits against the acetabulum. Decreased range of motion, the joint will be preserved, but the labrum will be significantly damaged. So you can pin them in situ, and that's fine. It's a safe procedure to do. Pin them in situ, and they heal up quite fine. This is the damage you see with a fairly acute slip. So there's quite a lot of damage quite early on in these children. Does it matter? We don't really know, because some of these children may well heal this kind of damage early on. But if you are going to put it in situ, you may want to think about doing a surgical hip dislocation and an osteochondroplasty to remove that bump. So providing you understand that that's what you may need to do, then you can pin them in situ. Is prophylactic pinning a good thing? Well, it can be in certain situations for young patients, endocrine problems, etc., but it's not without its problems, particularly if you use a screw that fuses the physis. If you use a growing screw, it may be different. So this patient at age 12 had slipped on this side, pinned, prophylactically pinned on this side. He came back to my clinic at age 24. He's got dysplasia here. He's got a large head, he's got a cam lesion and a short neck. So prophylactic pinning is not necessarily a good thing. And here, obviously, avascular necrosis. So what are the osteotomy options? So if you do an osteotomy here, this is the done osteotomy, through this line of the deformity where you can do angulation and translation, you can see that you get a correction and a normalization of all the mechanical axis. So the head, neck, mechanical axis is normal. If you do your osteotomy down here, this is distal to the apex of your deformity. You can correct the angulation, but you need to translate in order to make that normal. So this is that obviously the condition, the slipped epiphysis, the done operation you may be aware of. You need to check the perfusion, but you can get a good reduction and an anatomical reposition of translation and angulation. But you can also pin it in situ and then go back later on and do a much safer triplane osteotomy. But the triplane osteotomy is quite distal to where your deformity is. We know, therefore, that you need to do a fair amount of translation doing a triplane osteotomy, and the amount of correction you can get is only partial because you cannot translate enough to get a full correction of the angulation and translation. But if you do that as well, then again, you can see here, this is after a triplane osteotomy, you can still see that the bump still exists. And therefore, you may want to go remove that bump either arthroscopically or as an open procedure. So I think the message really is that whatever we do, whatever case and however you treat these conditions, you don't want to compromise total joint replacement. So as we said before, in hip replacement in young adults, approaching the results of the 60-year-olds, But let's just stop now. Don't compromise total joint replacement. So this is advice from an arthroplasty surgeon. Remember, think in 4D as well. Remember time in terms of children, the age, longevity of the procedure you're doing. Don't damage the abductors. Preserve your diaphysis. Don't use titanium screws. They're very difficult to remove. Remove metalware if you can, and we can discuss that because obviously that compromises and makes joint replacement more difficult. Don't leave cortical defects because they are problematic in terms of the type of stem you might use for joint replacement. So this is advice from an arthroplasty surgeon, and then if we go back to where we started from, looking at reconstruction, if you are going to reconstruct, think about what you can achieve, how long it's going to last for, and remember that at the end, the patients are likely to require a joint replacement. So joint replacement without compromise. Thank you.